has shown to me that mammography is even better in Kazakhstan than it's in the University Clinic of Cologne. Respect. This is the hospital I come from, the University Hospital of Cologne. It's a large university hospital in Cologne with more than 1,400 beds and a large oncology unit. And I work there as a consultant, actually for neuroradiology. We have a large variety of diagnostic machines, and one of them is the Icon Spectral CT. It's actually one of our working horses. It's doing a lot of investigations in all parts of the body for musculoskeletal reasons, for interventions, for neuroradiology. The machine was handed out to us as one of the first sites in the world, and that motivated us to bring out a lot of studies and in order to investigate which actually are the benefits of this machine. So, spectral detector CT is a method of dual energy CT. We use two energies in order to get a spectral information of imaging data. This can be performed with several methods. First of all, the dual source computed tomography, which is provided by Siemens, the KV switching method, and the spectral detector. The spectral detector has a special architecture which is transparent to high energies, so that we have a layer that is absorbing the low energy photons and a layer that is absorbing the high energy photons. This technology allows us to, first of all, calculate virtual monoenergetic images in a range of 40 to 200 kV and to perform material decomposition. So what does that help? First, the uniqueness of this detector is you don't need any additional radiation when conducting the scan. You can conduct the scan and afterwards reprocess the imaging data. And you have a perfect match of the image data acquired in both layers of the detector, in opposite to the other dual energy techniques. So the low kV images are giving us a boost of contrast, and the high kV images give us less contrast, but are able to reduce artifacts, which may be of great benefit. Then we have the material decomposition maps for iodine, for example, for the subtraction of iodine, for uric acid, for the atom number in the voxel, the electronic density, and we can, for example, depict calcium or subtract calcium from the images. So now looking at the clinical benefit in the everyday routine, we have to show that this machine is actually better in several regards, which could be the image quality, which should be improved, the lesion detection, the lesion characterization, the radiation dose. We would like to have a contrast dose reduction, and of course there should be at the end some economic benefit. We cannot perform investigations that are more and more expensive. So is that the case for the dual energy, dual source CT? Let's look at the image quality. First of all, we conducted a study that aimed to show what has already been thought of, dual layer CT. We conducted phantom studies that compared the performance of the different dual energy methods, the dual layer techniques, the KV switching technique, and the dual source technique. We found that the noise to contrast ratio in the dual layer CT is considerably lower than for kV switching and the dual source, especially in the low kV ranges, where this machine has a dedicated advantage. What does that help? For example, if we look at the data of a CT angiography, we see a sheer boost of contrast, which can be used now in several ways. Either to depict smaller vessels that we could not see before and give them a good contrast. Then we can enhance images that are of suboptimal contrast. We don't have to target the exact correct time of the images, but also for a patient, for example, who is in cardiac failure, we might still get optimal contrast images where we could not get these with conventional imaging. Then we could also use this to reduce the contrast reduction. This was performed with 70 milliliters of contrast medium. We could also then take 50 or 40, which is of economic benefit and also of benefit especially to the patients with a poor kidney function. And we can also use this to reduce the radiation dose. Looking at the numbers, we see this is because there is a more than 2.5-fold increase of contrast associated with the low kV imaging, which is then giving us a wonderful image because the noise does not play such a role anymore. The contrast is so good that the noise more or less disappears in the images. And you see very bright images and find that we have to adjust the window settings for these images. Looking at small vessels, for example, in the lung, we showed in a study from my colleague Rosa Hokam that we find that now we can see smaller vessels, not to the tiniest extent, but if you're looking, for example, at peripheral lung emboli, this will help you a lot to find these because you still have a good contrast in these vessels. This is actually a study where we investigated the vessels with a venous contrast. It's not a CT angiography, but it's a venous CT from staging. And we found that the contrast boost from the venous contrast and the low kV images is actually better than the conventional arterial phase, which helps us to depict the plaques, for example, in more detail, and also the vessel wall might be depicted a lot better. If we use this technique in the liver, for example, we find that we can see smaller lesions here. It's like hypodense lesions in the liver, which are very tough to see in the conventional images in comparison. So this might help us to detect the lesions to a larger extent. Now, sounds good, but still we have to optimize our settings in order to, first of all, not get lost in the flood of data, and also in order not to say, well, these images are not good because we're not looking at them at the right way. So we conducted studies to aim at the problems that are appearing when we perform low kV imaging. So our goal is to make low kV imaging the new standard of care for diagnostic imaging. For this purpose, we showed that we need other window lengths and window width for the patient, so that, for example, Philips can say, now we have a brain scan and we give an automatic window length, window width for the brain, for the liver, for the lung. And this is helping us, especially for the vessels and the high contrast structures. The most difficult domain for computed tomography is actually the brain. Why is that? We have only a very low contrast between the gray and the white matter. There's only a difference of 10 Hounsfield units between gray and white matter. So it's difficult to depict changes and to detect early demarcations of infarctions or edema. So here it is very crucial to improve the images. But we found actually there's also problems with low KV imaging in the brain because, for example, there were beam hardening glaring artifacts of the skull that were impairing the imaging there. And also we have a lot more grizzling small dots and points in the images that are actually not supposed to be there. So in this range, we found that actually the 40 kV images were not what we wanted to, and we asked Philips and Haifa to if they could improve this, and they actually did a very good job and reduced the glaring artifacts with a post-processing algorithm as reaction to our study. Still, we are now working on getting a smoother depiction of the brain. But what we can see for sure is that the basal ganglia and the gray to white differentiation is very much better with computed tomography. Catch some breath. Let's go to metal artifacts. Reducing metal artifacts is the domain of high KV images. And these high KV images are very good for small artifacts, for small structures. Just, for example, like the screws in the spine or the screws in the lower limbs. In these areas, there is a very strong reduction of artifacts which might be clinically beneficial. For example, here at the spine, this is post-operative scan of a patient that underwent spinal surgery, and afterwards he had trouble with his legs, pain, and it's always the question, is there some hemorrhage in the spinal channel? And we will have trouble with the MRI, and we will also have trouble with conventional CT. And you see, for example, that performing a post-processing with OMR might lead to new structures in the bone that are misleading, which are false artifacts, and also might not solve the case for us very well. But here, for example, the 200 kV images perform quite well. Let us see still the myelin in the spinal channel. Going to larger artifacts, we also find that there is some potential for the 200 kV images, but the starvation artifacts are too strong to really say that there is a great potential for low kV imaging. So therefore we conducted a study that we published right now, where we compared the high kV imaging with the post-processing with OMR. And we found that actually in a lot of cases there is additional benefits of these methods to one of each other, so that we can recommend the high kV images with the OMR imaging. And there's always one thing to say: OMR, like the post-processing, leads to artifacts in the bone and the adjacent structures right at the border of the implant here. We have a very good observation of the bone in the high kV images. This can also be used for dental implants, where we find a very good reduction of artifacts. This could be used for CT angiographies in order to see the entire vessel, and it could also be used to detect tumors in the mouth and ear and nose region. Going to smaller structures, we studied stents, coronary stents, in order to perform enhanced imaging of coronary arteries. Here we also find that the instant lumen is becoming a lot larger in the high KV images, but there's always a trade-off with contrast and the stent depiction. So actually, myself, I would say, like with 90 kV, I would be optimal. I would prefer these images, but I can then see, is there a patency in the stent where I might not see it before. In this regard, we took these stents and took them to France, to Lyon, in our suitcase, where they have the first photon counting computed tomography. That's the next generation that will come after the dual layer CT. And we put the stents in there with a plug here, in order to see if we can depict this plug in more detail. So the photon counting CT has one special feature. It does not need any transformation of the signal anymore to light, and also no shimming. Therefore, as we have this direct translation, we also have a higher image resolution, and you find that there is a really superior image resolution in comparison to the dual layer CT, and also, however, trade-offs of contrast and noise to be regarded. This is a study where we imaged then the electrodes of brain stimulating procedures. And here, for example, we found that the high KB imaging fails. It does not really improve the quality. Here the OMAR is improving the quality quite much, which is dependent on the material that is being used and the starvation artifacts that are being induced by the metal. Let's go to lesion detection and get some more interaction in this scene here. So we have these boosts of contrasts and just a little increase of noise, and we see that there is a boost of contrast of these lesions, and I think they are quite difficult to see from back there. Let's start with the first case, where we have a patient with a hepatocellular carcinoma who received a microwave ablation for the liver and was then imaged first with conventional imaging and then with low KB, where we find this additional liver lesion that was barely seen before and also missed by our colleagues, for example. Next case, a patient with trouble in the legs and a known lymphoma. Do you see the metastasis? I had a very hard time, and the colleagues from Borgreffe also had a hard time and really appreciated these images. We have quite many cases in which we find spinal metastasis that we didn't see before, because we actually usually don't look so much at the spinal channel when doing the staging. And here it really helps if we have a boost of contrast, because we really pick up the lesions quite much better. Another 50-year-old female with ovarian cancer, for our colleague, had a lesion detected in the low KB images in the right breast, which turned out to be a breast cancer with an architectural lesion and also a correlate in the MRI that was performed and was biopsied and proven. And also a patient with soft tissue metastasis. You see the soft tissue metastasis. Here's a soft tissue metastasis to some more extent, but here it truly helps to use fusion images. And this is also a feature that I really appreciate. You can take the conventional images and then put the iodine map as an overlay to this. You really get a boost of contrast. You cannot miss it anymore. You have some false positives because there are some small vessels that are appearing as injections into the muscles, but it really helps you to pick up these lesions. And in a melanoma patient, this could be really of importance, because we know that in melanoma patients we have to resect all tumors that we can in order to improve the outcome of these with the current immunotherapies. This patient with a depiction of a pulmonary emboli, which you can now also detect with the iodine mapping. This is really striking because it leads you to the thrombus that is here and very hard to see, but you are really pushed that there is some lung emboli there, and you will find it when you're looking at it. So let us look at lesion characterization. There's often some findings where you recommend an additional MRI, PET, and you want to find out what it really is because you're not 100% sure. It's like a young lady, 35 years, and you're not 100% sure that this is benign, or you're not 100% sure that this is malignant. So here it helps to use a spectral glass that is given as an addition to the spectral viewer. And you can now see the contrast of the lesion and the iodine density in milligrams per milliliter. And you can, for example, for this perirenal lesion, you can see that there is no contrast enhancement in it. It's an atypical cyst, but because it's not truly in the parenchyma of the kidney, you might have been disturbed by the appearance. Then the common thing with the lung noduli that we find every day, and then we say, according to Fleischner criteria, we suggest that there should be another scan in 6 months, and 12 months, and 24 months. And sometimes there are even small pulmonary lesions that are growing after 24 months. I've already seen some of these. And it helps in these cases a lot to have the iodine density, because it says that here it has a iodine density of over 3 milligrams per milliliter. The threshold might be about 2 milligrams per milliliter to have a specific saying that this is suspicious for a malignant lesion. And this would help us a lot, or it helped us a lot in order to say this has to be biopsied, and this was then done with an open resection of the lesion. Then we have here a lesion that we see a lot of cases, and we say, okay, this is probably benign. And we are being confirmed that it is benign because there is no iodine density. But there is also cases where we say, okay, this is probably benign, or maybe the patient had some contact to asbestos or something like that. But then we find that it is taking up iodine, and it leads us to the diagnosis of pleural carcinosis of this patient. This is really, really helpful. Then we have patients with pancreas carcinoma. Here you see the pancreatic head, and this pancreas carcinoma is already known, it's quite a large lesion, but would you ever say here or there is the demarcation line of this tumor? You would have a really hard time. And here it helps to have the low KV images, because you can see the hypodense extensions of the lesion to a larger extent. And also you can see the healthy tissue a lot better. Then we have a patient with EPMN, an intraductal papilla mucinous neoplasia. And we also see these noduli that are one signal of malignancy, and we can also then investigate these noduli in regard to their contrast enhancement. This might help us to say this EPMN is benign and this one has to be taken out by surgery. I have a cooperation with a company that is producing blood clots. I found out when having dinner with them that they are producing blood clots in order to test their thrombectomy devices. And I thought it was very interesting to see these clots finally when I got them, because they have a defined histology. We know this is a white blood clot when you have a thrombus in the brain. These are the old ones that have been there for a few hours, because the erythrocytes are being washed out of the thrombi. These are the mixed ones, which are quite solid, and the fresh ones are really fluidy. So what we found out is that we can actually take spectral CT to differentiate these to 100%. You could say this is the proportion of fibrin, and this is the proportion of erythrocytes in the thrombus. So this has some implications, because we can see this, say this might be the origin of the lesion, and this might be the age of the lesion. This helps us in stroke imaging. And in the current study, we also showed that these fibrin clots are associated with a poorer outcome of the patients. So a lot of other a lot of other clinics are not really don't really know about spectral CT, but one clinic does. We have a stereotactic neurosurgic department, and they truly love our spectral CT and bring all the patients to it because they like the VNC mode of the images. They like that the calcium can be subtracted from the images. Why does that? Because they always have these contrast-enhanced planning scans, and then they are figuring out how to get into this lesion. And they really have troubles when they get to this calcification to puncture through this. So this is a serious problem to them because they cannot plan and replan such a procedure. It's also dangerous to the patient. So they really use this VNC mode to quite some extent. Also, we're currently conducting studies, clinical studies, in regard to iodine quantification in tumors. In contrast to MRI, we now can quantify the iodine in a lesion. For example, we find that in lymphomas, cerebral lymphomas, we have a boost of contrast, or a very high level of contrast with more than 7 or 8 milligrams per milliliter, and it differentiates the lesion from glioblastoma. This could be used, for example, as a diagnostic criterion. And also, it can be used in order to differentiate the tumor from a necrosis after radiation, for example, in tumor recurrence. Then we also have these iodine overlaps here at the mouth, in the mouth region. It's a patient who had already had a surgery, and then we always have the trouble, is it a scar tissue, or what is it exactly? And we find that the hypervascularization helps us to define the lesion and also depict the lesion for the surgeon, and would guide us to do a rebiopsy or a surgery of these patients. Another study from my colleague, Grosse Hochkamp, showed that we can also differentiate kidney stones to a large extent. We got a bunch of different kidney stones and could differentiate them by their spectral imaging features. Here's another patient, and you see the spine. This is a bone lesion, but where is the bone lesion? We have a lot of metastases of bones that are destructive or sclerotic, and we easily find them in the computed tomography. But we also have all these bone infiltrations in the trabecular bone, for example, that are actually marrow-infiltrating metastases. We don't see them in the conventional computed tomography. But we do have a special iodine uptake, and we can also quantify this iodine uptake. And this helps us to say this is probably a benign lesion. In this case, this was a bone-infiltrating tumor. And we also found that there are some cutoffs. We have difficulties here with the closeness of calcium in iodine, but with high levels of more than 4 milligrams per milliliter, we can say this is quite specifically a bone metastasis. And we can also then quantify this in the images in detail. This product has not been released yet, but we are testing the prototype right now, and it's coming in the fall from here, released by Philips. And here you see the conventional CT and calcium subtraction of the computed tomography. And this helps you here in the clear fracture that you see to depict the edema in the end plate region, which correlates very nicely to the MRI. So if you have a patient with a fracture, you might find an edema, and you will not say, we need another MRI in order to confirm that this is actually a new fracture, and this is the old fracture, but you will be able to say this by using a spectral computed tomography. Then we have patients undergoing CT interventions, as with every other imaging machine as well. And here we're conducting a microwave ablation, and it helps us to see here is a rest of a lesion which has not been detected before, and we cannot see it due to the artifact of the conventional CT. Here, the high KV imaging helped us in some cases, and it also helps us to quantify the residual iodine uptake in the areas of the microwave ablations in order to say this is scar, and this is a reactive hyperperfusion, and this is a residual tumor. So let's come to the last point. Can we transform these images and this information to an economic benefit? Well, we have a lot of lesions where we say this is either benign or malignant, it's very small. We could say here it has a washout because it's much clearer in the venous phase than in the arterial phase. With the low KV imaging, you will have a very much clearer image of this little cyst, and you will also say for sure that there is no iodine uptake of the lesion. So does that have any economic benefit? Yes, it does, because you will not say anymore there is an additional ultrasound necessary, or there will be another MRI necessary. So by being able to say this, you will save cost to your department and to your clinics. So we conducted a study that selected all unclear lesions from our department from 1 year, which were 140, with an FNH, adenoma, hemangioma cyst, HCC, metastasis, and cirrhotic nodules, and we classified them by different observers if they were secure about their saying this is this and this and this or not. And this for the different modes, for the conventional imaging and the dual layer CT imaging. And we found that actually it helps a lot to use low KV images, and also even more to use the multi-parametric approach with iodine maps. So these are really giving us a boost in confidence. So therefore we had an improved sensitivity and specificity and in predicting the dignity of the lesions. So at the end we had 112 lesions where we were not 100% sure, and we recommended a CT follow-up and scanning for confirmity of the diagnosis. We had 52 lesions in which we did not perform a CT anymore, and thus we reduced our follow-up exams by 46%. So calculating this through for the follow-up exams and estimating some numbers, what this would cost, we calculated for us that we would save probably about 90 to 120,000 euros, so about 1 million rubles a year for our department alone, and only for liver lesions. So there's, the confidence for other lesions as well. So overall, I can say for sure that the dual layer imaging helps us a lot in clinical routine, and we recommend it for more patients than we can actually scan. There is an improvement of image quality, and there's also, as you could see, an improvement of lesion detection and characterization. The boost of contrast helps us to reduce the radiation for the patient, which we are currently studying in a lot of detail for the different indications. There is a possibility to reduce the contrast medium, and there is an economic benefit by using this technique. With this, I would like to thank you for your attention, and if you have questions, I'll be glad to answer.
Thank you for
Микрофон говорите, пожалуйста, иначе я скоро перевожу.
Thank you for good and absolutely interesting report. I would ask you about contraindications. There is contraindication to this method or not?
There is hardly any contraindication. It's the same like for a conventional computed tomography.
Okay.
You will have the same radiation dose exposure, so this would be a contraindication for children. And you will have a contrast medium exposure, which is a contraindication for people who are severely chronically ill in regard to their kidneys. And people who who have allergies against contrast media. So it's classical problems for conventional computed tomography.
Classical, nothing more, yeah?
Mm-hmm.
Okay, how long time we use it method?
For 2 years now.
2 years. Thank you.
We've scanned more than 5,000 patients.
Добрый день. Насколько я понял, на некоторых ваших слайдах было написано...
Микрофон скажите, тогда там переводить будут. А вон там стоит микрофон, сзади вас.
Насколько я понял, на некоторых ваших слайдах указано напряжение на трубке 200 килоэлектрон-вольт. У нас стандартная аппаратура работает где-то 125, но максимум 135 килоэлектрон-вольт напряжения. Соответственно, она требует совершенно другой рентгеновской защиты. Я правильно понимаю? То есть для постановки такого томографа нужна совершенно другая система, в общем, радиационной защиты, чем к обычным томографам.
There's a physical difference between KeV and kV. The kilovolt voltage for the scans is, as for the conventional computed tomography, 120 kilovolts. Or you can also conduct the scans with 100 to 140 kilovolts. The virtual reconstructions are then conducted from the different energies that are hitting the detector, which are about 50 to 70 kilo electron volts. And from this, there are virtual reconstructions from these 50 to 70 to 40 to 200 keV, which can be conducted as a virtual calculation. So actually, these 200 kilo electron volts do not have anything to do with dose.
Если я правильно поняла, технология позволяет понять причину окклюзии в сосуде. Это тромб определенной давности или это не тромб? Верно я поняла или нет? Если речь идет, например, о причине ишемического инсульта или дистальной эмболии.
This remains to be proven, actually. We showed that for our thrombi that we found, and we can also imagine that it would help a lot to differentiate between plaques, ruptured plaques, and the thrombus itself. There are more factors to that than fibrin and erythrocytes. There are also thrombocytes. And there is a lot of preclinical work and clinical work to be conducted in order to help solve exactly this problem that you are asking for, to say, what is it actually? Is it a thrombus? Where does it originate from? And what is the true etiology of the thrombus? But the information could be in these images, yes. Спасибо.